We are going to discuss now ST segment elevation acute coronary syndrome. This was earlier called STEMI. STEMI. No, we don't call it as MI. We call it as the STEMI, we call it as MI. Non-STEMI, NSTEMI, we don't call. We call it as non-ST elevation ACS. Non-ST elevation ACS. This is academic capstone. The essential clinical frameworks, guidelines, and landmark literature. I'll go slowly, but profoundly. You understand. If you have any doubt, please let me know. Okay. This is curated for general medicine pages of internal medicine postgraduate curriculum. Here in our this one, I am going to mute everyone so that you will not be able to open it. Okay. If it is not visible, you message me or one of you call me. Not visible or audible. Look at this, these gears. Several gears are there. 2026, the GRACE registry has come in BMJ that has established how we have to assess a patient for angioplasty and then reperfusion. 2008, we have got the Netherlands Heart Journal, the heart score has come. It told us how we can discharge a patient who is non-cardiac pain and who is no-risk patient. Such a patient can be discharged, that we have seen from the 2008 heart score. And then 2014, we have got the AHA-ACC foundational guidelines have come about the antithrombotic therapy, and early invasion has become vogue from 2014. 2018, there was a universal definition of myocardial infarction has come. Now we have classified the myocardial infarction now into type 1 and type 2. Majority of you may not know myocardial infarction has got two types, type 1 and type 2. That has started in 2018. 2021, the chest pain assessment which we have seen, the approach to chest pain guidelines have come, and the standardization of the evaluation of acute chest pain through high intensity pathways, we have seen that. Now we have got 2023, we have got the ASC-ACS, European Society of Cardiology, American Cardiology Society, the modern culmination unifying the STEMI, NSTE-ACS. Earlier this was called NSTE-MI. Now we call it as non-ST segment elevation acute coronary syndrome. These pathways are crystallized in 2020. To date, this is the benchmark process from 2006. It is modern clinical pathways evolving until from the copper gear to the blue gear now. The resident checkpoint here is if a patient presents with chest pain, which of these guidelines governs the first 10 minutes of my decision making and which governs the next 6 months? Do you mean to say that you need to remember all the guidelines? Nobody in the world can remember all the guidelines. Nobody cannot apply all these guidelines in one go. So there must be a synthesis. That synthesis, timeline synthesis, is what you are seeing through your content expert here. You are not expected to memorize the 6 isolated guidelines. You are expected to understand how they operate as a single machine. The machine will have 10 gears. All of them will work in one direction to move the machine in a way you want. Heart score gets the patient out of the ER. Fourth universal definition tells you what is happening at the tissue level. ESC 2023 algorithms tell you how fast to act, and GRACE score tells you who needs to go to the cath lab immediately. These are the triages you have to use. Now there is an ischemic signal, the fate line, the ST segment. Don't be obsessed only with the ST segment. You should read the ECG as a whole. There are several changes which are not reflected in the ST segment. So the entire ECG as a tool you have to use. NSTE-ACS, clinical evaluation, diagnosis, postgraduate internal medicine curriculum, part 1, isolating the ischemic signal. Okay, I have a confusion. Atypical pain, is it GERD? Is it gastritis? Is it anxiety? ECG is normal. Borderline troponins are not elevated. Should I send away the patient as gastric trouble? This is a high volume situation, high uncertainty situation. Not only that, high stake, cold is a high volume situation, but it is not a high stake situation. It's not like that. High volume, high uncertainty, high stake. What do? I should use filter. What is that filter? Risk scores, advanced ECG, high sensitivity troponin. Forget the word troponin alone. High sensitivity troponin is only recommended. If your lab is not doing, right, go to the lab people, tell them to do high sensitivity troponin only. Why? Ordinary troponin takes 6 hours for it to manifest. High sensitivity troponin, minutes, you can see the raise. Ask for HS troponin, not regular troponin. Risk scores you have to know, heart score, Grace score, syntax score, all those things you have to know. And then what are the ECG changes which should point me in a particular direction, I must understand. And the uncertainty to prevent missed acute myocardial infarction, missed acute coronary syndromes is progressively narrowing by using these filters. And finally, a definitive diagnosis of ACS can be made while safely discharging the non-cardiac patient. That should be your movement from chaos to perfectly differentiated diagnosis of chest pain. What is the clinical filter? NSTE-ACS diagnostic funnel. What is then? You have to first use the clinical filter. Clinical filter, are you having chest pain? Is it radiating? All those questions are there. But most importantly, apply heart score and Grace score. Quantify the baseline pretest probability. Heart score, I told you last time, 0 to 3. The pretest probability of ACS is very low. You can send him home. Between 4 to 7, it is intermediate possibility, probability is there. You cannot discharge. You need to keep him, observe, evaluate, and then only decide. Above 7, 8, 9, 10, heart score, you have to rush him to the cath lab. That is the first filter. What are the components of heart score? We will see. Then the Gray score also we will see to decide about what sort of modality of reperfusion I will use. Then you use the electrical filter. Immediately within first 10 minutes, you must get a 12 lead ECG high stake test. This is to identify acute actionable coronary syndromes. And then the most important thing is 0 hour biomarker. The moment the patient comes while taking the ECG, the blood is drawn, biomarker, high sensitivity troponin is tested, and the fourth universal definition as per WHO has been is in place, and that has to be used. Confirm the cellular injury. Cellular injury is not myocardial injury. Cellular injury does not tell you the etiology. Cellular injury tells you to look for the etiology. Definitive NSTE-ACS diagnosis can be made. Again, clinical filter, electrical filter, biomarkers filter, definitive conclusion about NSTE-ACS, non-ST segment elevation acute coronary syndrome. Now, the rapid try is the heart score. What is heart score? HEART. History, very supportive of ischemic heart disease, 3 points. Okay? 2 points. Probably ischemic heart disease, 1 point. No evidence of ischemic heart disease in the history, 0 point. 0, 1, 2, 3. Okay. ECG, definite evidence of ST segment elevation. Equivocal ECG, normal ECG. 0, 1, 2, 3 point. Age, less than 45, 45 to 65, more than 65. 0, 1, 3, 2 points. Risk factors, no risk factors, 1 to 2 risk factors, more than 2 risk factors, 0, 1, 2, 3 points. Troponin, flat, normal. Initial troponin, 0 troponin. Very raised, 2 points. Normal, 0 point. So, 1 point. Like that, you acquire the points for H, E, A, R, and T. This is a hard score published in Scandinavian Journal in 2008. Now, if the score is 0 to 3, my patient with 0 to 3 score can be discharged and managed as outpatient. Alternative non-cardiac diagnosis is mostly pertinent. The risk of major acute coronary events will be less, 2.5% or less. That means very low risk. If the score is between 4 to 6, intermediate risk, 20.3% major associated coronary events will be there. And these people should not be discharged. They must be admitted and clinically observed, and how their troponin behave, how new ECG changes come, and evaluate with GRACE score and then syntax score to triage them to the cath lab or to triage them for bypass or do something else. These are between 4 and 6. 7, 8, 9, 10 scores, the risk of high MACE in 6 months is 72.7%. Very high risk. These must go for early invasive reperfusion therapy. This is the first to try. Remember how to apply heart score and triage the patient out of the ED or admit and observe or go to the cath lab. 3 directions developed to predict major adverse coronary events. MACE means major adverse coronary events within the next 6 weeks, optimized for emergency department triage to dictate initial disposition of the patient. There is no arbitrary or sort of random way of deciding. Everything is guided. The moment you hit a patient of chest pain in your outpatient or in the ED, first apply the heart score. And the heart score requires an ECG, a history taking, looking at the risk factors quickly and giving a blood for troponin and getting the report in 15, 20 minutes, and also the age of the patient. Now, I have to use the GRACE score. I will show you at the end of the presentation how to calculate the GRACE score. What are the variables in the GRACE score? Age, heart rate, creatinine, heart failure pump, cardiac arrest, ST deviation, biomarkers, high sensitivity troponin. That means you would have calculated all these things, ordered for creatinine, look for Killip class of heart failure, cardiac arrest presentation, ST segment is evaluated, biomarkers are sent. How does these points come? This is a weighted scale. That means age has got certain weightage, heart rate has got certain weightage, and then creatinine like that. So how it works, I will show you at the end of the presentation. Heart score, GRACE score, syntax score, all 3 of them I will show. For the moment, you understand this is a weighted score based on 6 variables: age, heart rate, creatinine, heart failure, cardiac arrest, ST deviation, biomarker. What does it do? It predicts the 6th month risk of death and myocardial infarction, guides the timing of invasive revascularization, whether you should do immediate or early or ischemia guided. The revascularization cath lab procedure, either a stenting and angioplasty or a bypass by the surgeon, can be 3 types: immediate, early, and ischemia guided. That can be obtained by looking at the GRACE score, not looking at the patient's face or pulse, or asking his relative whether we do bypass or angio. That is not that way. It is exactly guided by the GRACE score. Nobody has got a say here. Derived from a 14-country multinational observational cohort. There is a robust evidence about the GRACE score. Now, I have finished the clinical filter. How? Heart score, GRACE score. Now I come to electrical filter. Total occlusion, beautiful, elevated, coving, upsloping, ST segment, the obvious signal, the signature of myocardial infarction or acute coronary syndrome, the signature change. It may not be there in all the patients. It may show sort of, like this, an ST T is elevated, but there is a depression followed by the T, and there is a ST and T together are depressed. Here, these signify subtotal occlusion or active plaque rupture. This is called the nonce signal. Obvious signal, nonce signal. Okay. NSTE-ACS is electrically diverse, unlike ST elevation ACS. That means several changes can tell you it is NSTE-ACS. What are they? Absence of ST elevation does not equal to absence of critical ischemia. You have seen ST elevation not there. Certain, maybe 70-80%. But you cannot exclude a critical ischemia in that patient. High-risk patterns demand the same urgency as the STMI. What are those high-risk patterns? Using the electrical filter further. This is called Valence syndrome. Valence syndrome is a high-risk filter. What is that? There is a significant, deep, symmetric ST-wave inversion in V2 and V3. Where do we observe? Lead V2 and V3. What I look for? Is there a deep, symmetric T-wave inversion without ST change? It's critical, severe proximal LAD stenosis. This is the LAD. Severe proximal LAD stenosis is predicted by this change. This is called Valence syndrome. If you don't see ST elevation, don't think he does not have classical evidence of infarction, and don't discharge him or don't delay the treatment. Criteria: deeply inverted or biphasic, as you have seen here. This is a biphasic T. Biphasic means up and down. One stroke is up, the other stroke is down. That's also significant. Inverted or biphasic T wave, where do I look for? V2 and V3 leads, not anywhere else. Without significant Q waves. There is no Q wave here. There is normal downstroke, no Q wave, often during a pain-free interval. That means Valence syndrome person, he will have all classical symptoms of pain. By the time he comes to you and you take the ECG, now I'm better, sir, I don't have any pain. That gives you a wrong assurance that it may not be heart attack. But this change should not be missed. This is a high-stake pattern, Valence syndrome, symmetric, cup-shaped, deep, T inversion or biphasic Ts in V2, V3, in the absence of Q waves, in the absence of ST segment elevation, is Valence syndrome a high-stake? This one, it tells me that the proximal LAD is shut off, is completely closed. I cannot but take him to the cath lab. Now, De Winter syndrome. What is De Winter syndrome? The converse of that. Here, instead of inversion, we have very peak T waves, hyperacute T waves, and the base is much wider, unlike the T waves of hyperpotassiemia. In hyperkalemia also you get T waves like that, but they'll have a narrow base. Here a wide-based, tall, conspicuously present acute, hyperacute T waves in again V2 and V3. Acute LAD occlusion. This also signifies LAD occlusion. This is an equivalent of ST elevation LAD, present in 2% of LAD occlusions. You cannot miss De Winter sign. Upsloping ST depression at the J point. This is that. This is a, see, you see upsloping ST depression at the J point and continuing into a tall, positive, symmetric T inversion in the precordial leads with wide base is what is called De Winter syndrome. Clinical filter, electrical filter, classical ST elevation, classical changes, reciprocal changes in the other leads, And and I have got the balance syndrome changes or the de-Winter syndrome changes. One other important thing is new onset bundle branch block. How do I know it is new onset? There is a left bundle branch block. LBB is there, pattern is there. But patient's previous ECG, 1 year old or 6 months old ECG, is not. That means he is presenting with a new LBB. New bundle branch block, either LBB or RBB. More robust is LBB. A new onset LBB is also a criterion for high stake situation. So I told you 3 high stake situations. David Valence syndrome, De-Winter syndrome, new onset bundle branch block in the absence of Q wave, in the absence of ST segment elevation should not be concluded as normal. They should not be discharged. They must go towards the cath lab. Now, patient is suspected with acute coronary syndrome and non-ST segment elevation. Why we said non-ST segment? This is what we are talking. ST segment elevation, ACS already over last week. Now, the focus on absolute delta change in the troponin. What do I order? Not normal troponin. I have to order high sensitivity troponin. What do I do? 0, 1, 2. American Association recommends third hour also. Better to have 0, 1, 2, 3, at least 0, 1, and 2. European Society says 0, 1, and 2 is adequate. American Society says if these are normal up to 2, then do the third one also. If already there is evidence in the delta, you don't have to do the third one. Okay. So that is the high sensitivity probe. Now there are 3 branches. 1, 0 concentration very high or first absolute delta change. What is delta? Delta is the difference between the 0 and the 1 or 1 and the 2 or 2 and the 3 is the delta. Delta is the difference. Delta means difference. Okay. 0 concentration highly elevated or highly elevated means how highly elevated? 99th percentile of the normal value. Above the 99th percentile of the normal value. What is 99th percentile? I will tell you later on. 1 hour absolute delta change is also significant. That is the red line. That is the rule in. Admit to CCU. Early invasive therapy. Angiography must be done within the next 60 minutes. Within 90 minutes total. Okay. Does not meet rule out or rule in criteria. That means it is neither normal nor elevated via media. Then don't discharge. Observe and get a 2 hour, 3 hour maximum, third hour troponin and echocardiogram also you do to look. This is the PU focus, the regional wall motion abnormality. Another test also we will include all those who are in the middle run. Now, 0 hour concentration is very low, normal, and 1 hour is absolute delta change is very minimal. After 1 hour, there is no increase in the troponin. It was at the baseline only. This rules out the diagnosis. Discharge the patient. Outpatient testing for further workup of his symptom. You understand? So 3 branches. Rule in, high initial delta, initial HS troponin or delta troponin, or moderate and not conclusive. Observe very low or normal. And even delta of 1 hour also is not elevated. Don't have to admit him, but discharge. You have to understand injury from infarction. Injury is lack of blood supply to the tissue. Tissue is crying. That is injury. And total cutoff, tissue is dead. That is infarction. Common condition, elevated high sensitivity troponin, more than 99th percentile of the upper range of the norm. Examples, injury can occur in sepsis, in CKD, in heart failure. That means the troponin will be almost elevated in these conditions where there is no actual cell death. It's only myocardial injury. Myocardial infarction, rise and or fall of the HS troponin plus clinical ischemia ongoing. That is a myocardial infarction. And clinical ischemia means what? Symptoms, New changes, imaging evidence in the echo, regional wall motion abnormality, there is a loss of viable myocardium. Now, the middle rung is myocardial infarction, that is raise and or fall of the HSTN as a high sensitivity troponin plus clinical ischemia. The blue box is the clinical ischemia. Based on the fourth universal definition of myocardial infarction in 2008, 18, these three classes, myocardial injury, myocardial infarction, supported by clinical ischemia. Elevated troponin alone means it is a marker of the injury, not a diagnosis of infarction. ECG is normal, serial ECGs are normal, you admitted him, and there is delta troponin. It's not increasing, but there is some elevation. That means there is myocardial injury due to some other cause, not due to acute coronary syndrome. I am now contrasting type 1 and type 2 myocardial infarction. Type 1 MI, plaque rupture, timeline. Phase 1, there is a vulnerable plaque. Most of the people around 40, 50s, already this plaque buildup will be there. There is a lipid-rich core inside. LDL and other molecules are here. A thin fibrous cap, but still blood is flowing, and he is not manifesting any ischemia or infarction here. Then what happens? One day, the thin fibrous cap ruptures and exposes the LDL and other oxidative contents, the thrombogenic contents to the blood, and acute environment for platelet adhesion, aggregation, and activation has come, and that is called the phase of rupture. And finally, those things form a thrombus. This is a white clot, this is a red clot. This thrombus formation, NSTE-ACS will develop. Still some flow is there, not totally occluded. If totally occluded ST segment elevation, there is a 90% or 80% occlusion, severe narrowed artery, reduced flow. Primary coronary event, atherothrombosis. What is this? Atheroma is this one. Atheroma went into thrombosis. Atherothrombosis due to rupture of the fibrous cap. The fibrous cap usually here is thin, unlike a non-vulnerable plaque where the fibrous caps are very thick. Okay, that may narrow the vessel, but generally they don't progress this way. Okay, what is the consequence? Requires this particular state, requires aggressive antiplatelet and anticoagulant therapy to halt the thrombus formation, propagation, and complete occlusion. This is about the MI due to plaque rupture timeline. Then what is MI2? MI2 is there is oxygen supply to the heart through the coronaries. There is a demand by the myocardium. If there is a supply-demand mismatch, supply is less, demand is more, then you will definitely end up in myocardial infarction type 2. What is the supply being less? Hypoxia due to any cause, hypotension, severe anemia. The other day, 4-5 days back, one woman came with increasing chest pain. Troponins are rather normal. Her hemoglobin is 5 grams. And she has a type 2 myocardial infarction because of oxygen supply less. Now, the treatment is not angiography. Correct the anemia by blood transfusion to start with, and maybe with other measures. And vasospastic angina, the pringimetal angina also, coronary spasm, that produces oxygen supply less. Oxygen demand when it occurs in sepsis, tachyarrhythmias, severe hypertension, tachycardia, demand goes up. There are several other conditions which increase the cardiac muscle demand, and the supply and demand mismatch is there. Ischemic imbalance scale occurs, supply-demand mismatch, not the cause of acute plaque rupture as we have seen here. This is type 1 infarction. In type 2, there is no plaque rupture. You may have non-vulnerable plaque, but plaque rupture is not the cause. What is the consequence? Don't rush into angiography and bypass. Treat the underlying condition. Antithrombotics are not indicated. Urgent angiography is generally not the solution. In fact, you should not give antithrombotics for a type 2 myocardial infarction. See, is it not a great message for all of you? Now, what is the matrix? Matrix is a table. Type 1, type 2. Primary mechanism, plaque rupture or erosion, atherothrombosis. Type 2, ischemic, oxygen demand supply imbalance, coronary angiography, acute thrombus, ruptured plaque. Normal vessel or stable, fixed coronary artery disease. You don't have to do coronary angiography. Only for exclusion you may do it. Classic triggers, often spontaneous. There, we have an underlying trigger. AFib is there, right ventricular overload is there, and then sepsis is there, acute bleeding is there, hypoxia is there, underlying cause is there. Primary management, aggressive antithrombotics, early invasive angiography and treatment. There, reverse the underlying cause, treat the underlying cause and the physiological trigger. This must be kept in mind by all residents. Distinguishing between type 1 and type 2 is the most critical cognitive step in NSTE-ACS inpatient management. This has come in the 2018 guidelines, the fourth definition of revision of the myocardial. Okay. Now, NSTE-ACS, Unified Diagnostic Blueprint. What is that? Clinical, okay, the first level, heart score, grace score profile. Number 2, electrical filter, 12-lead ECG, vector analysis, Valence syndrome, De Winter syndrome, left bundle branch block, all those we have seen. And finally, the delta and the H troponin 0 level, 1 hour, 2 hours, 3 hours. That will be the biomarker. So clinical, electrical filter, biomarker filter. In and through is that laser light going here, you can see. That confirms the type 1 NSTE ACS, which is an imminent revascularization procedure requirement. This patient requires cath lab and immediate revascularization. Okay. An ECG pattern without biomarker context is incomplete. There are some ECG changes, biomarkers are normal. What does it mean? There is no evidence of tissue crying. So you must have an ECG change and also have biomarker. A biomarker without ECG changes is only an injury. It is not. Troponin elevation without clinical context is noise. That is not music. You don't want noise. How do I evaluate? A troponin elevation per se is not infarction. It must have clinical base and also electrical base. Diagnostic certainly requires alignment of clinical filter, electrical filter, biomarker filter. And across all the three vectors, there are three vectors, if all of them align, then the diagnosis of non-ST segment elevation, acute coronary syndrome is imminent and revascularization is important and immediately to be taken off. So, filtering the noise, core takeaways, triage with precision. Use heart score for early disposition of patient and send him away from the ED. Heart score is not to confirm, it is only to exclude mostly. Grace score is to time the invasive strategy for admitted patients. Heart score decides whether he should be admitted or he should be observed or he should send to cath lab. Grace score tells you when you do an invasive procedure. Respect the nonsense. What is NSTE-ACS? Heights in high-risk stakes. That means classical signature ST elevation is there, unmistakable. Anybody will tell. In the absence of that, you should look for Valence, De Winters, and left bundle branch. And the absolute HSTN and also the delta of the marker, biomarker. Define the disease. Elevating troponin is injury. Adding ischemia makes it myocardial infarction. Always differentiate between plaque rupture and thrombosis type 1 and oxygen supply demand mismatch type 2. This is all the takeaway from the first part. Second part is pharmacological management and revascularization guide. First 20 hours, NSTE-ACS clinical pathway, algorithmic triage, high sensitivity biomarkers, acute medical management. We will see. Type 1 MI, we know there is a plaque rupture and there is an ongoing thrombosis. Type 2, there is no plaque rupture, but the blood supply demand ratio is altered. This part we have already understood. Now, typology, differentiating type 1 versus type 2, the fourth universal definition guidelines. We are using triaging, we are using the two scores, heart score and risk score. This is again evidence-based medicine, risk stratification. Diagnosis, we don't embark on single troponin value, that to ordinary troponin, we use HS troponin, and the ESC guidelines says 0, 1 and 2 hours, US guidelines say 0 and 3 hour path. Stabilization, anti-ischemics, acute myocardial demand reduction, beta blockers, and then the calcium channel blockers. Vessel patency to be established, antithrombotics, clopidogrel and other drugs, P2Y12 inhibitors, and anticoagulants. So, typology, what type I am dealing? And did I use heart score and gray score? What is my initial troponin and delta troponin? And am I using the beta blockers and CCBs to reduce the demand? Am I using the platelet inhibitors and anticoagulants? You must question yourself whether you are doing that. The heart score, we told you already. History, ECG, age, risk factors, and troponin. Components are 0, 1 and 2 points for each. I have already narrated. 0 to 3, 2.5% only risk for the major associated coronary events. Low risk people, they can get out of the hospital now. Conservative management, evaluate symptoms. 4 to 6, risk is 20%. And then immediate intermediate action, admit for clinical observation, serial troponin and serial ECGs will be required. And also the echocardiogram to look at the regional wall motion abnormality. 7 to 10, risk is very high, 75% risk, and high risk patient, high stake patient. Early invasive strategy is indicated within 90 minutes, perfuse the occluded culprit vessel. Now, the next one is the Gray score. Gray score, we know there are age, heart rate, systolic blood pressure, serum creatinine, heart failure, cardiac arrest, ST segment, elevated cardiac markers. So the critical threshold is, if you do the Gray score, I'll show you how to do it in the web. And if it is more than 140, it must be calculated. For every patient of acute coronary syndrome, Gray score must be worked out, and if it is 140 is the cutoff, anything more than 140, early invasive treatment is the answer. Less than 140, you have an option of delayed strategy, but early invasive. Now, this is the 0 hour, 1 hour, 2 hours, 3 hours. Whenever there is chronic myocardial infarction, the troponin is elevated, but it is stable, no fluctuations, the gray line. Whereas in acute myocardial 0 hour, 1 hour, 2 hour, the sharp delta you will see. This concept of delta, particularly for HS troponin, is essential in your mind. Don't look at one drop value and say it is normal or abnormal. Look at the delta. This already we have shown. Now, rapid diagnosis. Now, European Society of Cardiology 0-1 hour algorithm, HS troponin 0 hour versus 1 hour, very low baseline, no significant change, green channel, discharge the patient, investigate for alternative diagnosis. Or high baseline already, or there is significant delta at the 1 hour, admit to ICU, echocardiography you do, demonstrate regional wall motion abnormality, early invasive therapy, angiography, red pathway, rule in. Now, intermediate values not meeting the rule out criteria, there is not much of increase in the first hour, second hour, then wait for 3 hours, draw the third sample, and in the meantime do the echocardiography, clinically observe, serial ECGs and monitoring you see, the amber pathway, observe and decide. Okay. Now, European Society Cardiology 02 algorithm, US 03 algorithm of the AHEACC 2021 guideline. This one says 0 and 1 hour, at the most 2 hours only. Here they say 0, 1, 2, 3. If 1 and 2 are not rising, wait for third hour and then decide. That's all is the difference. Now, what are the anti-ischemic medicines I give? To reduce hemodynamic stabilization and acute anti-ischemic treatment to reduce the demand. Beta blockers must be given. When you say must, always there will be contraindication. What is the apavada or contraindication or exception? Heart failure, very severe acute heart failure, cardiogenic shock, high degree AV block. If you have any one of the three, don't give beta blocker. Otherwise, everybody is a candidate for beta blocker. Initially by needle, later by oral. You can start oral within the first 24 hours. If the patient is not able to swallow or unconscious, then you can give him by needle also. These reduce the heart rate and lower the contractile force and reduce the myocardial oxygen demand. Then suppose beta blockers are contraindicated. Then what do I do? Give calcium channel blockers. These are vasodilators and they reduce the demand. Which type of CCB I use? There are three types. We have to use non-dihydropyrimidines, not the dihydropyrimidines like your nifedipine and other things. Non-DHP we have to use. Verapamil and diltiazem. If beta blockers are contraindicated, use amlodipine combined with the beta blocker. Non-dihydropyrimidines and dihydropyrimidine combined with the beta blocker for refractory ischemia or suspected vasospasm. Nitrates, that is sublingual nitrate or nitroglycerin or nitrocontin or any type of nitrates we are using. Generally use long-acting nitrates. Use short-acting nitrates because situation is acute. Okay, somebody is having chronic pain, you can have a long-acting pain reliever. Somebody is having acute pain, you should give which works in few hours, few minutes. Symptomatic relief of angina via venodilatation. Nitrates produce symptom relief by venodilatation. Okay, contraindicated in 2-3 conditions. Right ventricular infarction, don't give nitrates. Last time also I told you. Severe hypotension, don't give. And if you have used Viagra, something like that in the recent 24 hours, PDE5 inhibitors, particularly Viagra type of drug, you should not give nitrates because it precipitous fall of blood pressure comes. So what are the contraindications? Beta blocker, what calcium channel blockers I use? When I use why I use nitrates? When I don't use nitrates, RV infarction, severe hypotension, recent PDE5 inhibitor. Now, you have seen the arch. For any arch, there will be one central stone that is called the keystone, capstone or keystone it is called. If you remove the stone, the arch will collapse. What is that stone? That stone is aspirin. Aspirin is the keystone of antiplatelet therapy in NSTE-ACS. Aspirin is acetyl salicylic acid aspirin. You should not use entry-coated aspirin. You must use soluble aspirin. How much? 150 to 300. Chewed or swallowed for rapid absorption. Suppose I don't have soluble aspirin. I only have ecospirin. Don't worry. Powder it, then mix it in water and drink. How much? 150 to 300. This is the keystone therapy of antiplatelet therapy. Anything else is an add-on treatment on aspirin. You have to use DAPT, double antiplatelet therapy. In the DAPT, the fundamental keystone is aspirin. You add another agent. How does it work? It is a COX-1 inhibitor, irreversible inhibition of COX-1 enzyme. Okay, what does it do? Then prevent thromboxane A2 synthesis. When the thromboxane A2 is the key molecule for platelet to aggregate with one another and propagate the white clot. So if you inhibit the thromboxane A2, you will prevent platelet aggregation. What is COX? Cyclooxygen is one. Cyclooxygen is 6 types of cyclooxygenases are there. We are interested in COX-1. The COX-1 inhibitor is aspirin. What is the clinical bottom line? The absolute cornerstone of NSTE-ACS therapy is aspirin. Must be administered immediately to all patients even before you make a firm diagnosis. If you are highly suspicious of acute coronary syndrome, give aspirin without without absolute contraindication, regardless of what is the second companion antiplatelet agent or anticoagulant you are going to give. Irrespective of that, aspirin must be given. Now, what are the companion therapy for the dual antiplatelet therapy? DAPT, dual antiplatelet therapy. One is already decided. The central stone, the aspirin. Now we have got the P2Y12 matrix. P2Y12, P2Y receptor blockers. There are three drugs are available now for us: clopidogrel, ticagrelor, or prasugrel. Clopidogrel, ticagrelor, or prasugrel. Clopidogrel is a prodrug. It has to get converted into another drug before it acts, and it is irreversible, slow, and variable onset. Ticagrelor, it itself is the active drug. It can be reversed, very rapid, very potent. And prasugrel is a prodrug, irreversible, very rapid, highly potent. Which do I use? Clinical niche is default choice if high bleeding risk is there. Somebody has got high HBR, high bleeding risk. Clopidogrel is the choice. Patients require concomitant oral anticoagulant therapy if they are requiring warfarin or decomerol you have to give orally, then clopidogrel is the best choice. When there is a need for concomitant anticoagulant therapy or when the patient has got HBR, high bleeding risk. Ticagrelor is the choice over clopidogrel in moderate to high ischemic risk condition without HBR. What is HBR? Patient who had got previous stroke, TIA, or any procedures and history of bleeding risk, you should not give ticagrelor. Patients proceeding directly to cath lab and PCI with known coronary anatomy, prasugrel is the best agent. So which agent I decide as the companion antiplatelet drug in the dual antiplatelet therapy is decided by this table. Contraindications and warnings. Clopidogrel, few contraindications. Okay. Watch for somebody who are non-responders for clopidogrel. Other than that, there are no contraindications. Okay. Ticagrelor, specific side effect, transient dyspnea. And prasugrel, prior stroke, TIA, and people above 75 are lean fellows. Who are less than 60, you have to adjust the dose in elderly and in the lean patients, and should not give in prior stroke and TIA. Now, what is the anticoagulant matrix I use? I have got 3 drugs now. Unfractionated heparin, conventional heparin, second one is enoxaparin, low molecular heparin, fondaparinol. What are the good and bad of each? Okay, mechanism of action binds to antithrombin, IV administration is required, preferred route in the emergency scenario. Enoxaparin, anti-10A factor, that is 10A inhibitor, anti-2A also, it can be given subcutaneously. Fondaparinol, synthetic selective factor 10A inhibitor, subcutaneous is the route of administration. Monitoring requires, the half-life is only 4 to 6 hours, requires frequent APTT monitoring, short half-life. Enoxaparin 12 to 24 hours, depending on what you have chosen. Predictable, weight-based adjusting, no routine monitoring is required. Fondaparinol, long half-life, no monitoring is required. Clinical niche, preferred if the patient is heading to the cath lab immediately, give unfractionated heparin IV, 5,000 units. Reliable watt-based bridging, adjust for renal impairment, reduce the dose of enoxaparin. In the 0.4, you use the 0.3 syringe. Lowest bleeding risk among all the 3, must add IV unfractionated heparin if directly proceeding to the cath lab. So what I do, if I choose fondaparinux, I give a bolus of a single initial shot of unfractionated heparin, take him to the cath lab, and also give fondaparinux. By the time the procedure is over, fondaparinux takes care. This is the anticoagulant. These slides are very important for you. You see here, the anti-ischemic therapy, beta blocker, calcium channel blocker, nitrates. Antiplatelet therapy starts with aspirin and then clopidogrel, ticagrelor, or prasugrel. Antithrombotic, anticoagulant treatment, unfractionated heparin, fondaparinux. Here, mind, there is no room for thrombolytic treatment. Unlike there is an option in STEMI, you can use thrombolytic treatment. Here, there is no room for that. Synthesis. NSTE-ACS master mix. Patients present with acute chest pain. Assess the heart score. HS to see high sensitivity troponin 0 hour. You draw green branch. Heart score is 0 to 3. Basic troponin is negative. Delta is not yet available. Discharge outpatient follow-up green channel. Red or amber branch, heart score more than 3, positive troponin and delta, medical management, start aspirin, assess the bleeding risk, anti-ischemics, beta blockers, calcium channel blockers. Then, once you risk stratify using the Gray score, more than 140, STEMI equivalents are there, Winters, all these types of syndromes are there, unfractionated heparin, prasugrel or ticagrelor, cath lab within 24 hours. Immediate risk, enoxaparin, fondaparinux, ticagrelor, clopidogrel, ischemia-guided approach or delayed invasive. Now, this is the third part, the clinical blueprint of advanced workflows for revascularization, antithrombotic strategies, and secondary prevention also. Again, this is based on European Society of Cardiology 2023, AHA-ACC 2021, and the fourth universal definition of myocardial infarction. This is again the part 3 of them. Heart score, we know already 0 to 3 rule out. Gray score, rule in 140 or more. I have to go for this one. What are the variables here? Age, heart rate, SBP, initial creatinine, CHF lip class, cardiac arrest on admission, ST segment deviation, elevated cardiac mark. What are the variables here? H history, ECG, age, R risk factors, T troponin, particularly HS troponin. Now, the urgency gradient. Angiography, when I will do? Within 2 hours I will do, or within 24 hours, or depending on the ischemia as an elective procedure. Deep crimson color, criteria, very high risk patients, hemodynamic instability, cardiogenic shock, recurrent refractory chest pain despite medical therapy, life-threatening arrhythmias, VT or VF, mechanical complications like papillary muscle rupture, acute heart failure linked to ischemia, immediately within 2 hours. You must go. This is not STMI. This is NSTE-ACS. STMI anyway you have to do within 90 minutes. Early invasive, orange. Criteria for high risk, confirmed NSTMI based on high sensitivity algorithm, and dynamic STT segment changes are there. Gray risk score is more than 140. Then you have to take for early invasive procedure. Early means within 24 hours. Criteria low risk, no recurrence of symptoms, negative HS and troponin, Gray score is less than 40, non-invasive stress testing or CCTA preferred first. Then you do angiography later on. Okay, revascularization modality matrix. What do I do? There are 2 revascularization procedures. One is the PCI, the other is the surgery CABG. The CABG, coronary artery bypass grafting versus PCI. Which patient should go for cath lab and angioplasty? Which patient should be in the hands of surgeon? This is the decision. This is heart team decision. The heart team is comprised of cardiologist, internist, and cardiothoracic surgeon, anesthetist. All 4 are in the heart team. Optimal profile, patient is low risk fellow, single vessel disease, double vessel disease, low anatomic complexity is not there. I did a syntax score, it is less than 22, go and do PCI. Earlier, there was a lot of debate. Why he is doing angioplasty, he should have done bypass. Why he went for bypass, he should have done angioplasty. This confusion is once for all solved. Nobody need to tell whether you should do that, empirically or by your intuition. You go by the syntax score. Syntax score is less than 22. Single vessel disease, double vessel disease, relatively stable patient, optimal profile, high risk. This is one group. The other group is very elderly, 80-year-old fellow, high surgical risk, very frail patient. I cannot take him for surgery. Though he requires surgery, I cannot take him. Surgery is contraindicated. There is immediate urgency. Cardiogenic shock is there. Ongoing ischemia is there. I have to do the save the patient. Do PCI. One scenario, suitable patient, you do it. One surgery non-suitable patient, do PCI. Or CABG, optimal profile, complex multivessel disease, syntax score is more than 22, diffuse disease, you can't say disease is here. Every part of the coronary anatomy is occluded. In such a patient, angioplasty is impossible because you cannot repair the entire plumbing line. You have to put new plumbing line, that is the CABG. What is the clinical context? If he is a diabetic, if he is a multivessel, strong survival benefit of CABG. The presence of diabetes decides in favor of surgical treatment, CABG, and multivessel disease, or left main disease with high syntax score. Left main disease, optimal profile, stable fellow, and then less than 22 syntax score, he can be managed with PCI. Left main disease, high syntax score, diabetic fellow, anyway you have to go. Or if the LV function is reducing, you should go for the immediate CABG. Now, multivessel disease identified. Navigating the MVD, multivessel disease. Okay. More than 50% of NSTE is patient present with multivessel disease. There are two pathways. Pathway 1, pathway 2. We'll exhaust the pathway 2 first. Patient presented with multivessel disease and cardiogenic shock. Culprit lesion only during the index PCI. Routine immediate revascularization of non-culprit region in shock increases the mortality and renal failure. Stage non-culprit intervention after the hemodynamic recovery after 1 week or 1 month. This is for the person with cardiogenic shock with multivessel disease. Do the culprit vessel and repair the remaining thing later on. The pathway 1 is hemodynamic stable fellow. NSTE-ACS is there. Complete revascularization is recommended. If 3 vessels are blocked, tackle all the 3 vessels using PCI, can be performed immediately during the index procedure as a staged procedure or as a staged procedure also prior to discharge. Guidance: use fractional flow reserve. This is called FFR. Fractional flow reserve is an intravascular assessment or instantaneous wave-free ratio. This is called the IFR. FFR and IFR are two measurements done by the cardiologist while assessing the vessel intravascularly to evaluate the non-culprit vessels. If the non-culprit vessels have got FFR reserve, poor reserve, or IFR is very high, those vessels have to be tackled. If the FFR and IFR are within the acceptable range, those vessels can be tackled later. Okay. Now, CCU battlefield, days 1, 2, 3. You have done some procedure. He is in the CCU now. What are the days 1, 2, 3? What will happen? VTRV, ventricular tachycardia, ventricular fibrillation, peak occurrence in the first 48 hours. That's why they will tell doctors, no, after 40 hours, 48 hours, we cannot tell anything. How is the prognosis? The son and wife will come and ask. We can't tell, sir. 4 గంటలు అవ్వాలి. Means what? You are expecting these complications of VT and VF. Requires immediate defibrillation, amiodarone, and correct electrolytes and ischemia. That is one aspect because the sinus node triggers the VT-VF. That is why it is pointed here. Now, high-grade AV block can occur. That is an electrical complication. Common in the inferior wall myocardial infarction, RV myocardial infarction, RCA territory myocardial infarction, right coronary territory myocardial. often transient, responsive to atropine, and temporary pacing. You don't require a permanent procedure response to atropine. Now, there is a papillary muscle tear, rupture, there is a septal rupture, there is a free wall rupture. These are emergencies. These are mechanical complications. These are not electrical complications. Posterior medial muscle most vulnerable. Single blood supply from PDA, presence of a flash pulmonary edema, new holosystolic murmur, severe MR at the apex, papillary muscle rupture, ventricular septal defect, LAD or inferior infarct, patient presents with biventricular failure, set up in a high right heart oxygen saturation, requires there is a holosystolic murmur along the sternal border, new onset murmur, requires urgent surgical patch or closure. There is a free wall rupture, the ventricle wall itself ruptured, blood is coming into the pericardium, cardiac tamponade, electrical activity, pulseless, sudden pulseless disease, secondary to cardiac tamponade. That's also to be immediately corrected. What are the two important electrical complications? VTVF and high-grade AV block. VTVF, defibrillation, amiodarone, electrolytes and ischemia correction. High-grade AV block, atropine may be sufficient, temporary pacing may be done. If there is a mechanical complication like papillary muscle rupture, ventricular septal defect, or free wall rupture, they must be surgically tackled. Now, bleeding risk problem. The Bleeding Baseline Academic Research Consortium. This is called ARCHBR Consortium. This is assess the bleeding risk, HBR, in the Academic Research Consortium, ARC. HBR is high bleeding risk. Rule, high bleeding risk is defined as more than one major or more than two minor. Okay, regarding the high bleeding risk, I have told you, severe CKD, and then the hemoglobin level less than 11, and then spontaneous bleeding within the past 6 months, moderate to severe baseline values of thrombocytes that less than 1 lakh, and chronic bleeding diathesis, active malignancy. Whereas minor criteria is more than 75, mild to moderate CKD, that is 30 to 59 eGFR, hemoglobin of 11 to 13, and prior stroke or TI. These are called the minor bleeding criteria. These things you have to keep in mind. Now, should I use triple platelet therapy or double therapy? AFB, NSTE, ACS. These golden rule is default strategies, oral anticoagulants, antiplatelet matrix, and these combination. Now, dual strategy, high bleeding risk people, high ischemia. Here, the slide I will share with you. You can see and read that. And DAPT tightrope is the duration and de-escalation. How long I give the double antiplatelets and when do I discontinue? Aspirin and clopidogrel or any other prasugrel or ticagrelor will be there first 3 months must, preferably up to 6 months. Continuing up to 1 year is a good option. So aspirin plus other antiplatelet agent usually should be given for 1 year and minimum of 1 month. Now, what are the long-term secondary prevention strategies? This is important. This is called GDMT. What is GDMT? Guideline Directed Medical Therapy. Optimum medical therapy, also called the guideline directed medical therapy. While I am discharging, I must write the GDMT. What is the GDMT? Lipid lowering drug must be prescribed. High intensity statin means 40 milligrams of rosuvastatin or 80 milligrams of atorvastatin must be given. And second one is beta blocker must be prescribed, preferably metoprolol or any one of the new generation beta blockers. Metoprolol, carvedilol, bisoprolol, nebivolol, any one of them, preferably metoprolol, extended release. Third one is you must give ROS inhibitor. That means either you have to have, I don't have the screen sharing. Don't worry. These are only a couple of slides. So just get along with what I'm the message. Long-term secondary prevention, lifelong prevention indicates 4 pillars. Pillar 1, lipid-lowering therapy. Means what? Lipid-lowering therapy, rosuvastatin 40 mg or atorvastatin 80 mg. The second pillar, beta blocker, metoprolol sustained release, nebivolol or these slides are available with you in next few minutes. Don't wait, think about the screen share. Listen to what I'm saying. Only 2 slides are there. I'm going to close it. I'm not able to share the screen because it is not available on this computer. Other computer got disconnected. Okay. So beta blocker should be given. Nebivolol, bisoprolol, carvedilol, metoprolol are the best drugs. Best is metoprolol. What is the pillar 3? I have to use RAS inhibition. Either sartan group, telmisartan, olmesartan, valsartan, losartan group, or ramipril, enalapril, captopril, that group. Either a pril or a sartan must be given. The fourth one pillar is SGLT2 inhibitor. Okay, irrespective of whether he is a diabetic or not. Now the treatment now is pillar 1 lipid lowering statin, pillar 2 beta blocker, pillar 3 S inhibitor, ARB, pillar 4 SGLT inhibitor. This is for the long-term prevention. So lipid targets must be achieved and you should not compromise on achieving the lipid target. And LDL-C must be less than 55 in a patient who had suffered NSTE-ACS, not 100 anymore. You have to keep the LDL-C less than 55. Sometimes you have to use PCSK inhibitors. Most of my patients who had NSTE-ACS, they are not controlled by rosuvastatin, atorvastatin. I add ezetimibe, not at control. Then I shift them onto PCSK inhibitors, an expensive proposition, but still it is worth it. You have to keep less than 55 LDL. Modern cardioprotection integrating the SGL2 inhibitors also, because heart failure class 1 indication SGLT, diabetes mellitus anyway SGLT, chronic kidney disease SGLT. Whatever way you see, SGLT inhibitors are the core treatment. Actionable item here, initiate prior to discharge in all patients in NSTE-ACS. Once hemodynamically stable and euvolemic, you put them on this SGLT inhibitor. Complete NSTE-ACS master algorithm, Triage, cath lab this one, antithrombotics, low bleeding risk, high bleeding risk, and then lifelong GDMT management. These are the various steps. Triage I have shown, and heart score and all that. Now I am going to show you the risk scores about that. And landmark clinical references are given in the final slide. I will share you the slide within a few minutes. I'm going to give you the slides also. You can see this is that DAPT, high double antiplatelet therapy. What I do, escalation and other things. Aspirin must be there, and clopidogrel or other antiplatelet agent at least for 12 months. The 4 pillars I was telling you: pillar 1 lipid lowering, pillar 2 beta blocker, pillar 3 is the RAS inhibition, and 4 is the SGLT2 inhibitors. Lipid target must be less than 55. You may have to use PCSK inhibitors also. Okay, now cornerstone is SGLT, either for heart failure or for diabetes or for CKD. The core is SGLT, so SGLT must be prescribed at the time of discharge. So the triage is now complete master algorithm. What do I do on triage? Gray score, heart score, and then cath lab, syntax score, and then CABG, what I do, vascular procedures, antithrombotics, when do I give, about low bleeding and high bleeding risk, and then the oral anticoagulants considered, and guideline directed management. And these are the various important references. Out of that, I have printed here only 6 important references, and I have shown you in that the initial engine with the gears. These 6 have found place in the engine. With that, this particular presentation is over. I'm going to show you the risk scores, What is the age? Less than 45, okay, 45 to 64, more than 65 points. Now, non-risk factors, 0, 1 to 2, more than 3 risk. I have put 65 and more than 3 risk factors. Initial troponin, more than 3. Okay. Then what happened? 10 points have come. This one is the real MAC risk is around 10%. A maximum score is 10%. He got that, then immediately he must go for abdomen cath lab. Versus another patient is less than 45, and then his ECG is normal, and then he doesn't have any risk factors, no risk factors. And then the heart has got 5 components, no. H, history, suspected, moderately suspected. Otherwise, we don't do all these things. Moderately suspected, suspicious, normal. EKG, less than 45, no known risk factors, and then serum troponin is less than normal limit. And what is his score? 0.1. What I will do? I will discharge him. I don't have to keep him in the hospital. Versus another patient who is 45 to 64, who has got non-specific repolarization changes, highly suspicious history, and then he has got 1 to 2 factors are there, and let's say he has got 3 times upper normal limit, then his score is 6. He must be admitted and evaluated. I showed you the less than 3, up to 6, more than 7. All the 3. So depending on that, you have to triage the patient. Now, we will look at the gray score, gray risk. Gray score, you see here. Gray risk calculator. Okay, what is the age of the patient? I put 65, heart rate is 127, BP is 90, creatinine is 1.8, cardiac arrest, no, ST segment deviation, yes, abnormal cardiac enzyme troponin, yes, Key class, rails and JVP, and then you have the score is 151. I told you anything above 140, you have to take him to the cath lab. Supposing he doesn't have CHF, then 136 has come down. Or it doesn't have abnormal cardiac enzymes are not there, then it has come down to 123 points. Now you see ST segment changes are not there, then 106 points. Like that, the gray score modifies. Or his blood pressure is normal, let us say 120. Then you say 96 points. The probability of death from admission to 6 months is 3% only. In such patients, you don't have to immediately rush to the cath lab. So heart score and gray score are essential. Once you decide to do the procedure, whether I do CABG or whether I do the PCI, that is angioplasty, whether I do the culprit vessel alone, whether I tackle all the problems is decided by the syntax score. Now you see the syntax score comes on your screen. Yeah. So that is the coronary anatomy. This is the right coronary and this is the left coronary. And it will ask you, when you enter the score, it will ask you, is it a right dominant or left dominant? The first question will be, you have to select the dominance. Usually 90% are right dominant, only 10% are left dominant. I select the right dominant, then it will ask you to tick the lesions in each of the categories. See? Okay, let us say proximal circumflex, I have ticked. And I have also ticked left mid LAD, and these 2 vessels are affected. Then the next variable will be, it will ask fill in the following variables. Total occlusion, yes or no. I say yes. Okay, total occlusion is there. Indicate first segment number T10, 7 and 10. Yeah, 7 and 10. Both are affected. Age of the patient. Okay, I say age of the total occlusion. Less than 3 months. Yeah, yes. And then blunt stump, no. Then it will ask, is there a bridging? No. Then finally, it will make you decide which particular procedure you have to take. Like that, you go on putting all these numbers And finally, the syntax score less than 22, then you don't have to do anything. More than 22, immediately you have to tag it. Remember, gray score, hot score, gray score, and syntax score. Okay. This is the end of the presentation. If you have any questions, you can type it out. This one is a very extensive presentation. We sat from what time we sat? 5:50, 5:30, nearing 7, 1.5 hours. Good. So I'll share the video and also share the PDF also. And the scores also, I will give you the link so that you will be able to apply those things. Okay. Now, anyone has questions?